The topic for today is Obstetric Emergency CBS session, and the speaker that we have here is Dr. Arun Raja Thangavel. He is a senior clinical fellow at Critical Care Guys and St. Thomas Hospital, UK. So you may take over.
Thanks, Fatma. Thanks for the kind introduction. It's all right. We have a good session ahead. So I've been taking classes on obstetric emergencies, and today we will be focusing on computer-based skills session, and this will be the first class in this topic. So myself, Arun, I work as a senior clinical fellow, as Fatima mentioned. I've done my European diploma in anesthesia and intensive care, and I passed the intensive care exam last year with the help of FOSS Academy, and it's my time to contribute back to the FOSS Academy, being a faculty. So first of all, congratulations to everyone again for pausing EDIC Part 1 and taking effort to appear for the EDIC Part 2, and you have all joined FOSS Academy, so you are in safe hands. And as far as I know, this is the only like coaching which is available for EDIC Part 2 in particular. There is no other class, even the EDIC preparation course, which is officially available from the ESICM, is nowhere close to this. You get a lot of exposure to similar exam type questions in FOSS Academy. So welcome you all to the class again. So objectives for today, we will get some more orientation towards how the EDIC Part 2 exam is going to be. That's the most critical part of passing the exam, understanding how the exam pattern is, how the questions are going to be. And for this session, we will have a CBS kind of questions. I have prepared like 10 questions in the obstetrics. In the CBS sessions, there can be like three kind of questions available. Either it can be a radiology or imaging kind of questions with some videos or static images appearing and a clinical scenario associated with that and couple of questions. Or it can be a big questions with multiple lab details, biochemistry, results available, and you need to tease out a diagnosis and a subsequent question. Or it can be a curve or a graph associated with the ICU. It can be anything. You have no idea from where they are giving the questions. So have an open mind when you appear for the CBS sessions. Although they are like simple sessions, the risk of failure in the exam is more with the CBS sessions actually rather than the CCS. CCS, we have a lot of clinical exposure, so somehow we can answer those questions. We have adequate time in our side. For CBS sessions, it's more like a quiz, rapid fire round. So it will be a total of 30 questions on the day of the exam, spread over 3 sessions. Each session will have like 10 questions. It can either be in a single module like radiology, all radiology and imaging in the single session, or it can be a mix and match of all the three types on the particular session. So within those 10 minutes, you need to answer 10 questions. That is the most challenging part. And the more time you waste on a single question, the less chances of completing all the questions and less chances of passing that session. So it's time critical. You need to be quick in reading the questions, coming up with a diagnosis, so you get chance to complete all the 10 questions within those 10 minutes. If you manage to answer most of the questions, you are almost nearly there with a pass. So that's the important tips on CBS sessions. So we will practice similar questions in our sessions and revise pertinent obstetric topics as and when needed. And I will try and modify your answers according to the expected examination standard. So some rules, let's keep it interactive and feel free to interrupt anytime and clear doubts. Interrupt me anytime, no issues at all. And try and answer as much as possible whenever you get a chance. Treat it like a mock exam. That's when you get most out of this course. And please, if possible at all, keep your videos on so I can see some faces to interact with rather than just seeing your names on the screen. We will try to give everyone an opportunity to answer like robin kind of questions. I am interested in knowing like who are the candidates who are like appearing for the exam this in couple of weeks, this May session. Can you unmute yourself or put a chat in the box so that we can prioritize you to practice your answering? Anyone appearing this May session?
Uh, all the aspirants are requested to switch on their cameras, and also if you can reply, do put it in the chat box.
Yeah, thanks. Thanks, Fatima. If possible, I know some of you must be working. It's not always possible to keep your mics and camera on. It's fine if even if you put in a chat or just or can unmute yourself and speak or keep your videos on. Otherwise, I will have to. Thanks, Christina. Fine. Anyone in particular appearing for the upcoming session? Am I audible, Fatima?
Yes, sir, you are audible to me.
Yeah. Okay, fine. Uh, I take it as a no for the upcoming session. So if most of you are appearing for the November session, I'm not prioritizing anyone.
Yes, I wrote in the chat box. I'm appearing for the next session.
Oh, sorry, I can't see chat. Yeah, some of you mentioned in chat. Now I'm getting so Mohammed. Give me a second. Right, so it's Mohammed Raga, Fatih, Elkhan, Anup, and Mustafa. So we will try to prioritize you guys who are going for the exams first. I will for like maybe ask you directly to answer. If that person is not available, maybe we can put it open to the others. Okay, everyone ready? Right. So the first question is like, I think I will go with Mohammed Raga for this question. If you can unmute yourself and come up with an answer. Can you see the question?
Yes, 32 years female, 3 weeks post delivery presents to induce breathlessness. She has cold breaths and PB 85 by 60. Blood gas shows metabolic acidosis and lactate of 8. What is the most likely illness? How will you manage?
Yeah, let me play
Please,
the video again. So this is the echocardiogram given to you. Sometimes they play such videos.
yes, this is postpartum cardiomyopathy.
Yeah, and will you manage?
In postpartum cardiomyopathy, this is post-delivery already. So just with supportive management, uh, we can add inotropes.
Yeah, and yeah, what kind of inotropes are the options? I mean, it's
Uh,
a general question. I'm sorry. Sometimes there can be specific
we have
questions
to
for
control
such
heart
questions.
rate.
Yeah.
We, we have to control fluid responsiveness first. If patient is fluid responsive, as MAP is already accepted, but patient has some metabolic acidosis.
Yeah. So that is end organ perfusion is not adequate.
Yes.
So we need to increase the cardiac output somehow. So we have
Uh,
few options. in the terms of inotropes, especially inodilators can be good in this scenario with some vasopressor support like dobutamine, milrinone, even levosimendan is being commonly used along with vasopressor support so that you maintain the perfusion as well. And yeah, advanced options like VA, ECMO,
We-
mechanical support devices if the patient really requires it. And Dr. Mohammed, can you explain the echocardiogram? What do you see, and why do you say it's peripartum cardiomyopathy based on this?
This left ventricular ejection fraction is low, and there's global hypokinesia with apical, like apical ballooning. Global hypokinesia, this is left ventricle.
Yeah, we cannot really see the apex here. So it would be helpful
Yeah.
if you, in your answering, frame it like it's a parasternal long axis view. We are not expected to be like experts in echocardiography, but at least the basic views and uh, our diagnosis based on the echo. If you can add it to the diagnosis, that would be helpful. Maybe carries a point, we don't know. Apart from peripartum cardiomyopathy diagnosis, maybe they expect with severe LV dysfunction. Uh, so just whatever you get like focused diagnosis, you can put it out in the exam so that you don't lose out on marks. One more question I have, like it can be open to the audience. What do you think of the role of bromocriptine in the diagnosis of peripartum cardiomyopathy? Do you use it? Have
Beneficial
you used
because I
any?
think prolactin has a main role in this issue. So prolactin is used as one of lines of treatment.
Sorry, I didn't hear your answer properly, doctor.
Prolactin is accused as the major cause for peripartum cardiomyopathy, and bromocriptine is used to control such a case.
Hmm. Yeah, there is some controversy in between the boards across the countries. Like American board is not keen on using bromocriptine. They don't suggest to use it, but Europeans definitely favor the use of bromocriptine. Especially one thing to note is if you are using bromocriptine, you should be using along with anticoagulation. Definitely with such severe LV function or dysfunction, you will be using anticoagulation anyway. But especially with bromocriptine use, it is advised to use along with anticoagulation. Thank you, Dr. Mohammed. I think next question we can put it to Fatih if you're available, if you don't mind
Yes,
taking the
yes.
question. Yes, go ahead, Fatih.
Okay, 20-year-old woman at 30 weeks gestation presents with sudden onset of severe headache, blurred vision, and hypertension. She has positive proteinuria. What is the most likely diagnosis and what is the first line treatment to prevent complications? Uh, of course, the patient has the symptoms of preeclampsia, and she's high risk to develop eclampsia as well, or to progress into eclampsia if not properly managed. The CT brain, which is shows a little bit of, although there is still gray matter and white matter differentiation, but might be there is features of mild brain edema. So our first line now to prevent complications is to control the blood pressure, to put the hemodynamic support and put the patient in a monitored area like a high dependency unit or ICU. The mainstay to prevent the progression to eclampsia and to control blood pressure in this context would be magnesium IV, by giving 2 to 4 grams loading and then 1 to 2 gram IV per hour, with monitoring of the renal functions, urine output, and knee clonus, to prevent the symptoms of magnesium toxicity or hypermagnesemia. In addition to this, of course, the patient would need full investigations, including CBC, complete blood count, urea and electrolytes, liver function test, coagulation assay, including BT, INR, and ultrasound abdomen to check the condition of the liver, especially condition of the kidneys, and fetal ultrasound as well to check the viability of the fetus, and if possible, if the symptoms are not well controlled or progressing, then we would think about early delivery. Early delivery, and of course, we have to use that what's called fetal monitoring or topography, CMG or CTG.
I'm going to stop you there, Dr. Fatih. That's a comprehensive answer. Excellent answer. Thank you so much. Yeah, for CBS sections, you don't need to be so elaborate, but if you may start with giving specific answers, if the examiner is looking for more answers, like if they are giving you a prompt, is there anything else you want to add? Then go ahead, give as much as possible so that you get the mark. But if they are happy with the initial answer, they will just move on to the next question just to save time. Yeah, you need to be precise in your answer so that you save time in your answering as well. So just be mindful of that. For the, for the purpose of this class, you are free to answer, take your time. But with the exams coming up in mind, I'm just putting you to be mindful of the
Thank
time
you.
you are taking up. And
Thank you very much.
what are the other features of cerebral edema in this CT? You did mention like gray-white differentiation. And what are the other features we say?
Sylvan Fisher is not obviously Sylvan Fisher, although we don't have all the cuts, but obviously I cannot see the Sylvan Fisher.
Exactly. The
Ventricles
effacement of the
also
sulci and gyri. Yeah.
Compression of the lateral ventricles is very important.
Yes, that's another thing, isn't it? Whether the lateral ventricles are compressed. Unfortunately, they don't give you like all the cuts in the CT images. Whatever the exam questions they gave for me, they just put it like a single cut, and we had to make a diagnosis. Sometimes it's not clear, unfortunately, but this is how the exam is. So we need to be prepared for just answering with a single cut as well. And yeah, as we discussed, lateral ventricles, compression, effacement of sulci and gyri, and white matter differentiation. And in such scenario, like I agree with the general management. What is the role of like mannitol or hypertonic saline if the patient really has cerebral edema, apart from management with magnesium? What do you think evidence says, or what is the practice?
The evidences are very poor regarding this issue, but usually when the patient develops signs of severe pre-herniation or lateral signs of lateralization, at this point it's life-saving measure. But usually we don't tend to use those measurements in pregnant ladies to avoid any kind of volume depletion, which might happen with this kind of with these agents, especially mannitol and hypertonic saline.
I totally agree with you that, Dr. Fatih. Mannitol, especially volume depletion, and even in the fetus, it can cause hypovolemia. That's the concern with mannitol. And hypertonic saline, we have very limited evidence of use in pregnancy. So that's the concern with that in case you are asked in any questions.